Hi, I'm Betsy Nicoletti. I'm here to talk about the transition of healthcare of the HCC codes from version 24 to version 28. So what's all the fuss about? CMS has proposed in February of 2023 that instead of using HCC codes version 24, which we're currently using, that they would transition January 1st of 2024 to version 28. So I'm going to talk about what that transition is going to look like, what the differences are going to be in hierarchical condition categories in version 28, and the compromise that was made. And the compromise is there's going to be a 3-year phase-in. In 2024, we'll use the risk score will be a third based on version 28 and 2/3 based on version 24. And then it will transition in the next 2 years. And at the end, I'll do a brief overview of HCCs. So HCCs, as you probably remember, were developed by Medicare to predict future costs and pay for patients who are in Medicare Advantage plans. CMS believes that some of these Medicare Advantage plans are upcoding, resulting in payments that are too high. And certainly we've seen that Medicare Advantage is one of the most profitable lines of business for healthcare insurers. Why does Medicare believe this? There have been multiple OIG audits of Medicare Advantage plans in the past few years, and it shows that in some cases, the diagnoses that are submitted and that result in higher payments weren't supported in the medical record. And then CMS analyzed for the same kind of patients, how much were they paying for Medicare Advantage and how much for fee-for-service patients. So they're removing, so HCCs, that's the model that Medicare developed. And in version 28 model, they're removing some conditions that they say didn't accurately predict costs, where the risk scores, the coefficients were small, the conditions were uncommon, or those conditions didn't have well-specified diagnostic coding criteria. The current HCC categories were developed a long time ago, and they were based on ICD-9. Version 28 takes advantage of ICD-10 structure and clinical concepts. So the number of HCC categories increases from 86 to 115, but the actual number of ICD-10 codes that has a risk-adjusted score that is assigned a coefficient decreases by 2,294. So right now, about 7,500 ICD-10 codes have a risk-adjusted factor. In version 28, there'll be 2,300 fewer of those. And remember, we do have this phase-in period over 3 years. Some common conditions aren't going to have a risk score anymore. CMS is using constraining, which means related HCCs are given the same coefficients. And something that you may have read about, and that was certainly talked about, when these guidelines were proposed, is that diabetes, which now has 3 categories, 3 HCC categories: diabetes uncomplicated, diabetes with an acute complication, and diabetes with a chronic complication. And they had different coefficients, uncomplicated and with complication, now are going to have one category with the same coefficients. So it's going to lower overall risk scores for patients with diabetes. There are additional codes that are going to be added to version 28. 268 codes that didn't map to an HCC category will. Many of these are in chapter 16 or 17. Certain conditions originating in the perinatal period or malformations and chromosomal abnormalities. So that won't make a big difference in many Medicare patients, but for insurance companies in the ACA marketplace, or if you have private commercial insurers that use the HCC model, that'll be a help for you in terms of risk scores if you're taking care of those kinds of patients, a younger group of patients. So you want to see the entire list. I did too. The citation is at the end of this presentation. So there are a couple of links. One is for a zip file that has two files in it. One is the list in text, TXT format, and one is in Excel. When you download the one in Excel, the left-hand column is the ICD-10 code, and it's alphabetized by ICD-10 code. The name of the condition, brief description, and then there are 4 columns on the right. The first and the second column are the ones that relate to Medicare HCC coding for Medicare Advantage plans. And you'll see the condition, and it'll show you which category that diagnosis code maps to in version 24 or 28, or it'll be blank if it doesn't map. And in the right-hand column, the last 2 right-hand columns, so columns 3 and 4, is for insurance companies in the ACA marketplace. So I just have a few examples on the next few slides of some of the conditions that will no longer risk adjust. Not meant to be inclusive at all. I know you're going to want to download the list yourself. Protein calorie malnutrition, hypoparathyroidism, some major depressive disorder codes. So in version 24, a few codes in F32 don't risk adjust. In version 28, more codes in F32 and some in F33 don't risk adjust. Some polyneuropathy codes, some angina codes, some aneurysm codes without rupture, thoracic, abdominal, and aortic ectasia, some atherosclerosis codes, acute kidney failure, acquired absence of great toe or other toes. Those were status codes that started with the letter Z. So again, these are just some examples. You're going to want to look for yourself. So you're going to review the file. If you then want to see what the coefficients are, what the risk scores are, on another slide, there is a link to the PDF, and it's Medicare's policy document. This is what we're doing. It's the document that actuaries love. But the coefficients start on page 183, and I've noted that in the slide. So you don't have to page through the first 182 pages. So you're going to want to review that. If possible, you're going to do a provider in-service on HCC coding and review your use of these codes. The basics have not changed. Follow ICD conventions and guidelines, code accurately and specifically. So now, if you need an overview of HCC coding, I'm going to do that now. And I did it purposefully in this order. I didn't start with the review, because if you came for what's happening with version 28, I felt like you should get that first. So HCC hierarchical condition categories are used by Medicare to establish the monthly rates for Medicare Advantage organizations for Medicare Advantage patients. And it varies payments by demographics, geography, and diagnoses. Demographics, age and gender, if the patient is living at home or in an institution, and if they're dually eligible for Medicare and Medicaid, and if they have end-stage renal disease. And then the diagnosis codes that are submitted in a calendar year by hospital inpatient and outpatient claims, physician claims, and other healthcare professional claims, social work, psychologists. It does not include diagnosis codes on labs and other diagnostic tests. And then geography. There are differences in expenses by county. And our RAF is the risk-adjusted factor, or the coefficient. So diagnosis code, first let me say, we don't calculate HCC scores by hand. It's done with software that's available on Medicare's website. Maybe it's built into your EMR, or maybe your organization has other software that does that. But it's diagnosis codes that are submitted in a calendar year from all of the clinicians that I mentioned earlier. So if a patient was an inpatient, then saw an outpatient cardiologist, then went to their primary care clinician, all of the conditions that are submitted on claims by all of these professionals are calculated into their risk score. It's not just a risk score based on what your practice is submitting. So that's one of the reasons why it's hard to calculate your own risk scores, even if you have software. All right, so related conditions are assigned in one category and only the most serious is counted. Two conditions in the same group are only counted once. So if you have a patient with two types of chronic complications of diabetes, it's counted once. In some instances, a higher ranked condition causes lower ranked conditions in the same category to be ignored. And unrelated conditions in different categories are counted. So the score is additive. You add up those scores, except for the caveats in the first three bullets. There's a thing, I call it as boosting, but it's really called disease interactions. When certain conditions occur together, the risk score gets an additional boost. So there's an additional score assigned. And I get asked this a lot. Do I have to submit on the same claim, congestive heart failure and COPD? No, it's the risk scores that are submitted in the calendar year to the payer. So you don't have to submit them on the same claim. And this disease interaction is still functioning in version 28. When we're assigning codes, we start with coding instructions in the tabular list and alphabetic index. We follow those instructions, official guidelines, and then the American Hospital Association coding clinic. Section 1 applies to both facility and outpatient services. Sections 1, 2, and 3 apply to non-outpatient settings. So for us in the non-outpatient settings, inpatient, observation from the facility, rehab facilities, hospice, non-outpatient settings. Section 1 and 4 apply to us in the medical professions. So if you are looking at guidelines and you see a guideline in section 2, but you are assigning codes in outpatient office of medical office, you need to be using sections 1 and 4 only. We code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. We don't code conditions which no longer exist. So we don't code acute stroke when the patient had a stroke last month and now we're seeing them for follow-up. We don't code neoplasm, malignant neoplasm, if the patient has no evidence of the disease and is no longer receiving treatment for the disease. Those are some examples of where the OIG found errors. So we put on the claim form conditions evaluated and treated at the encounter, chronic conditions that affect the treatment of an acute problem that the clinician has noted. I don't go up to the past medical history and say, oh, I think that affected this treatment. I'm looking for what the clinician says. We want to see a documented treatment plan that shows evidence of the assessment and the management or how that condition affects treatment. And all the HCC experts that I've heard, and I'm not one of those experts, I'm giving you the overview, say this is the gold standard. Condition, this is the diagnosis, status, stable, fine, worsening, plan. That shows evidence that the problem was assessed and managed at today's visit. So here we are, here are the citations I was talking about. This citation is, you're going to download a zip file, and there are the two documents in there, a TXT file, an Excel file that shows the HCC categories in version 24 and 28. And when we want the coefficients, we're going to look at this February announcement, which has the coefficients by age and demographics starting on page 183, and the categories and the coefficients there. And this is a policy and actuarial discussion. It's dense. What you're looking for is starting on page 183. And then if you're looking for what Medicare has to say for guidance about risk coding, the 2008 risk adjustment technical data document is still, very relevant. Section 6 and 7 relate to coding. And then the risk participation guide and the contract level adjustment, data validation. They know how to name these things. Medical reviewer guidance in effect from April of 2019. When you're reading these documents, pay attention to facility versus outpatient rules, because there is some distinction. And if you just Google you put what I have written in here in your Google search box, it'll find them. Thank you for joining me today to hear about the transition from version 24 to 28 and an overview about HCC coding. There is a lot more information about coding for medical practices on codingintel.com. So I hope you'll go and take a look at that. Thanks.